So I thought we could just go through a case and then go through the differential diagnoses. And then at the end, I hope you all listen and learn something, because we will have a quiz and the winner will get a prize. So the case is a patient we saw on AMU a few weeks ago, a 19-year-old male who was about to start university with no significant past medical history or no known drug allergies, with a background of no recreational substance use, including no history of nitrous oxide use or other recreational drugs such as cocaine or other drugs. He presented with a 6-day history of subtle lower limb weakness. So my next question is, what else would all of you like to know? So you can either unmute yourself or put it in the chat.
What else would you like to know? Come on, everybody. Subtle lower limb weakness.
Yep. So what other questions would you ask on history?
So it's 6 days, and before then he'd been perfectly fit and well. So there's a question, there's an answer there. Onset, is it gradual or sudden? And has he had a recent infection, viral infection? Because they're thinking of post-infectious something or other.
Okay, good. Anything else that you'd like to know?
Can you see the comments?
I can now. Breathing or bulbar changes, good. Any previous infection, gradual or acute. Anything else? Preceding trauma, very good. What if I add that he's good, nutritional intake and vitamin deficiencies? Okay, I was looking for that. So I think I'll just move on to the next slide. Okay, so we actually find out that before this, he's had a 3-day history of a sore throat, as well as cough, which was self-remitting, which was then followed by a 2-day history of a headache. A week later, he then developed tingling in his palms and the soles of his feet, as well as unsteadiness on walking and diplopia. He also notably had mildly slurred speech, which was picked up by his family and not really by himself. He had no history of trauma or falls, no significant family history. Importantly, he is a vegetarian. So could anyone tell me why this could be important in the context of lower limb weakness or abnormal sensation? Good, B12. So what could the diagnosis be with the B12 deficiency? So severe B12 deficiency, what could you possibly have neurologically, or the condition that can also happen with good peripheral neuropathy? And this can also happen with nitrous oxide intake, which is actually quite prevalent in the UK and other countries. So it's actually subacute combined degeneration of the spinal cord. He was also, as I said before, not on any current medication, as well as over-the-counter medication. So what does everyone think happened next?
Just go back a slide so that we've got that little text there. So there's the, so interestingly, the unsteadiness and the post-viral thing, we're all thinking of one peripheral diagnosis, but then suddenly he's got double vision, which changes the differential quite a bit. What happened next is where is he? Is he in casualty now?
Well, okay, let's say now at this point, he actually first presented to a local hospital. On this slide, he presented to a local hospital when he had the tingling in his palms and soles, but was then discharged for an outpatient neurology appointment. And then on the next slide, for the what happened next, he presented to an eye hospital. And so can anyone tell me what they think would have happened that would make him present to an eye hospital, and what would have been done next?
Go on, someone, unmute.
Be brave. You don't have to have your camera on.
Okay, so TM256 has given us optic neuritis, question mark.
Okay.
So he would have complained in that situation of a loss of vision, maybe
Yes.
in one eye. You mentioned double vision early, though.
Yes, he had double vision.
I think if I had double vision, I'd go to my hospital pretty damn quick.
Okay, I think we'll just carry on. So 3 days later, his double vision worsened. His balance and tingling in his extremities also worsened, but then he also developed mild weakness in his arms, but not legs. But what concerned him most was the double vision, which was very unsettling for him. He didn't have any swallowing difficulties, but did feel like some of the liquids he was drinking felt like it was going back towards his nose on swallowing. He had no backache, no urinary or fecal incontinence, and importantly, no saddle anesthesia.
Okay, and there's a comment there that says Miller-Fisher, question mark.
Okay. We'll go through differentials in a bit. Okay, so just a summary of the timeline of events. This is actually not the month he presented in, just for confidentiality's sake, so no one can identify this patient. But basically, he came in on, say, the 1st of January, presented with a 3-day history of an upper respiratory tract infection, signs and symptoms of one, likely viral, which was then self-limiting, and then had a 2-day history of a headache, which is again self-limiting. Then 7 days later, he presented with tingling. Well, he presented to a local hospital with tingling in the palms and soles, unsteadiness, diplopia, and mildly slurred speech, which wasn't very noticeable by him, but by his family members. Then 3 days later, he developed worsening diplopia, arm weakness, and presented to a local eye hospital, and then was referred to us.
So going back to the 8th of January, did he have any signs? Was he examined in the, I mean, double vision?
Oh, we don't have those notes from that hospital because he was discharged for an outpatient neurology appointment. And then on the 12th, when he was an inpatient here, he had a bit of nasal speech and was feeling that food was being regurgitated slightly, with just that subtle feeling of liquids going back towards his nose. Okay, so what would your differential diagnoses be in a patient with diplopia, visual disturbance, as well as sensory signs in the extremities, slurred speech, and a loss of balance? So Dr. Bihari has said Miller-Fisher, very good. Anyone else have any other differentials?
MS or stroke has come up.
Okay.
I mean, demyelination sounds very reasonable, doesn't it? In terms of peripheral neuropathy type things, together with cerebellar signs you've got there.
Yes.
It would fit very well with demyelination, except the respiratory illness doesn't quite fit there. The respiratory illness was pulling towards Guillain-Barré until he had all these upmotor neuron signs, which of course makes that impossible.
Yes. And less in keeping with stroke. Can anyone say what would be less in keeping with stroke? Poisoning, good one. Sensory signs can be present with stroke. Yeah. But I think it's more of the gradual onset of the symptoms. So stroke might be more sudden onset, more acute onset. Myasthenia is a good one, but it's not typical with sensory symptoms, so that's good. And then poisoning is a really good one, but what are you thinking about with regards to poisoning?
Lead.
Okay. Interesting.
Well, it's not something we see anymore. That was an
Carbon monoxide. Okay, also interesting. Sorry.
A tumor.
Oh.
So I always think demyelination, tumor,
okay,
and stroke should be your 3 answers in any patient's exam.
Okay, good. So now what to expect on clinical examination? I'll just give you the general exam for now. So his vital signs were regular, blood pressure was 110/61, so his normotensive, not tachycardic, with a pulse of 70 and regular. His SATs were 98% on room air, and he was under stress with a respiratory rate of 18. He was alert, looked well, had no obvious new rashes, and had mild dysarthria, but all his words were intelligible.
So you want us to tell you what you found on examination? Neurology, do you mean?
I want you to tell me what you think could be found on examination.
It depends how it's examined. If they do a proper examination, or if they just write down moving all four limbs, because I get he is moving all four limbs.
Okay, so it's moving all four limbs.
Come on, somebody, tell us what you think we're going to find.
Otherwise, we might be here all day.
No, we're not going to be all day, but tell us, do you mean neuro examination?
Neuro examination.
So, right, so everyone, you need to tell us somebody what you think you're going to find with tone, reflexes.
I guess what Yorissa is asking us is, if you think of what you know what the diagnosis is, what would you find to support it, i.e. in terms of reflexes and power?
Yes, so the problem is we don't know the diagnosis. We're all guessing.
Yes.
We're a bit nervous, that's the problem.
Fine, it's fine. Let's go through it.
Okay, so look, here we go.
Okay, so on eye examination, on inspection, his pupils were dilated at around about 6 millimeters, but reactive to light with no relative afferent pupillary defect. So that's RAPD. Visual acuity was 6 out of 6 with normal fundoscopy, which was actually done by the eye hospital as well and just confirmed here. So it is a true normal fundoscopy. There was no ptosis and the visual fields were normal. However, he had a complex ophthalmoplegia, especially on up gaze. He also had horizontal diplopia, which was binocular, so in both eyes in the primary position, but worse on left and right, worse on looking towards the left and right, as well as the up gaze, and almost normal abduction and adduction.
So just explain again. So when the patient is in the primary position, I was looking straight ahead.
Looking straight ahead. He has horizontal diplopia. So
okay.
Two figures, next to each other, side by side. But this is worsened when he looks either left or right or up. And then he had almost normal abduction and adduction in terms of movements of his eyes. He could abduct and adduct almost 90%. He had mostly a problem with elevation. So his looking upwards was limited and he could only elevate about 10%. So very impaired, but he could look down quite well, it was 100% intact. So basically he had a complex ophthalmoplegia affecting mostly cranial nerve 3 and some of the fibers of cranial nerve 6. So this is an example of a normal 9 gaze eye motility images. So if I just get the pointer up. So this is a patient looking, I've just used the arrows for convenience sake. Patient looking up and towards the right, patient looking just straight up, looking up and towards the left, then looking to the right side, straight on to the left side. So this is what the normal should be, but this is an example of what our patient had. So on looking towards the top right, he had impaired adduction in the left eye, which was worse than the abduction in the right eye. So if you see here, looking upwards, he had difficulty with looking upwards. And then on looking up and to the left, he had impaired adduction again, worse in the right eye in comparison with the left abduction. So this is just a reminder of what the different nerves are responsible for. Does anyone know which nerve is controlled, which nerve controls the lateral rectus? Yeah, RL6 SO4, good. So lateral rectus is the 6th nerve and the 4th nerve is the superior oblique. So in this patient, we mostly had involvement of superior rectus, inferior rectus, medial rectus, and inferior oblique, sorry. So now we move on to
So the lateral rectus was all right, was it?
the lateral rectus was,
Fixed. It's a partial third.
it's a partial third with some of the fibers of the sixth nerve involved.
I think abduction was impaired bilaterally to some extent.
By 80%.
And mostly a superior branch of the third. So up gaze very, very severely affected, and the rest of them partially affected with the lower branch.
So the partial third, and both eyes, can I just be clear?
Both eyes, bilaterally the same, equally affected.
So anatomically, it's getting a bit tricky. AMU's putting his or her hand up.
Oh.
Go on, AMU. Unmute. Have you got any thoughts? I thought there was a hand just there from AMU. They're not going to.
Okay, fine. We'll move on to the neuro exam. Okay, so neurologically, he had a Glasgow Coma scale of 15. He was orientated to time, place, and person. There's no pronated drift. His cranial nerves, 1, 4 should actually be included in here. 5, 7, 8, 9, 10, and 12. 11 and 12 were all intact. He had good power, which was 5 out of 5 globally, with normal tone, but he was areflexic throughout. There was no fatigability, and he had a good cough. In terms of sensory signs, in terms of light touch, it was reduced in his palms and soles bilaterally. This is, again, very subjective, but there was no sensory level. His joint position sense and pinprick were intact globally. And in terms of cerebellar signs, he had no nystagmus, mild dysarthria, subtle dysmetria, bilaterally, but no dystadical kinesia. He also had a normal heel to shin and a slightly ataxic gait, but it was not wide-based. And his Romberg sign was negative.
Ataxic gait.
Yep.
Okay.
So he was a bit unsteady on walking.
Okay.
But it wasn't wide-based.
And could he walk heel toe?
Yes.
No, not heel shin.
Oh, sorry, heel toe.
In other words, could he walk?
No.
He fell out, he'd fall over.
Yeah.
Okay.
So the impression that was made was that we had a 19-year-old male with a subacute progressive peripheral paresthesia with cerebellar signs, with the background of a previous viral, likely viral respiratory infection, with clinical features of complex ophthalmoplegia, areflexia, ataxia, and altered sensation peripherally. So now we come to the differential diagnoses. So you've done very well so far. Someone's mentioned Miller Fisher. We've had toxins, vitamin deficiencies. So very good. Anyone else has any ideas? I think someone mentioned stroke. So very good. Okay. So the top differential diagnosis would be Miller Fisher syndrome, which generally presents as an acute inflammatory it's actually mentioned axonal, neuropathy. And then the second would be GBS or Guillain-Barré syndrome, and then something called Bickerstaff's brainstem encephalitis. I'm not sure if any of you have heard about it. Yes, so CIDP could be on the differential, but this was mostly because this is quite acute onset that we didn't really consider CIDP, but well done, Adam. Myasthenia gravis, brainstem stroke or central lesion, syphilis, which can be a mimic of many things, Wernicke's encephalopathy if he had B1, severe B1 deficiency, botulism would be a really good differential because it is an acute cause for descending flaccid paralysis, and can also present with
So can I just be clear then? So botulism and myasthenia don't have sensory signs normally.
No, they don't. So that would be on the next slide, you'll see that would be one of the differentiating factors.
And what you might have with botulism though is sort of positive sensory signs sometimes with paresthesias. I think it's important not to be thrown by that. There shouldn't be any sort of negative sensory signs like actual objective numbness or reduced sensation.
Right.
And then also with myasthenia, so again, what would be against it is the sensory features, like you said, Prof. Miran, and they'd also unlikely not be areflexia with myasthenia. But otherwise, you can have unilateral or bilateral oculomotor involvement, ptosis, and the main differentiator would be the fatigability. And then tic paralysis would be another differential. However, there was no history of him being in an area with high prevalence of tics, no new rashes, and so this was unlikely. And then in terms of drug toxicity, he wasn't on any chronic medication. And then finally trauma, which he didn't have a history of. This is just a reminder about midbrainpons and medulla and what nuclei actually go through. So in the midbrain, you have the nuclei of the oculomotor and trochlear nerve, so 3 and 4. And then in the pons, we have the 5th nerve, 6th, 7th, 8th nerves, the nuclei of them. And then in medulla oblongata, we have 9th and 10th nerve nuclei. I don't know if you want to add anything about this.
No, other than just saying that that's sort of partly where that whole rule of fours thing comes in that people often use for mnemonics for brainstem anatomy. So yeah, basically the first, well, not so much the first 4, but 3 and 4 come from the midbrain, 5, 6, 7, 8 from the pons, 9, 10, 11, 12 from the medulla. It's just a good way of remembering where they come.
Okay, so if we go into a comparison of the differentials in more detail, so our number 1 differential would be Miller-Fisher syndrome because of the descending paralysis. But generally, Matt has told me that some of the symptoms can actually happen all at the same time in Miller-Fisher syndrome. So the ataxia, the cranial nerve ophthalmoplegia, and the peripheral neuropathy can happen all at the same time. So it's not typically a descending paralysis like botulism. So that would be the main differentiator between botulism and Miller-Fisher, is that botulism is more a sudden onset, true descending weakness, where it would start in, say, for example, the cranial nerves or and move down towards the feet. So Miller-Fisher syndrome, like I said, ataxia, areflexia, and ophthalmoplegia, whereas myasthenia gravis does not have ataxia or areflexia, but does have the ophthalmoplegia. And then Bickerstaff brainstem encephalitis, which I didn't mention before earlier, but was on the differential diagnosis because it is also, like Miller-Fisher syndrome, a variant of GBS. And the main differentiator is that there is altered consciousness, so altered level of consciousness with BVE versus Miller-Fisher syndrome, where the conscious level is intact. In terms of drug toxicity, here I was mainly referring to phenytoin, which can cause ataxia, but is unlikely to cause areflexia or ophthalmoplegia, and can result in an altered level of consciousness. And then in terms of trauma, you'd only maybe have the altered level of consciousness and maybe some ophthalmoplegia, depending on which nerve roots are involved in the trauma. And then finally, botulism has all of the features. But like I said, main differentiator would be also the history of botulism. There's generally no preceding illness, and the patient might present with abdo symptoms, diarrhea, abdominal pain, and the progression is much more rapid. Anything you want to add?
No, I think it's good.
Okay.
That's a fantastic slide, Yorissa. Well done.
Okay, so another summary of just going through GBS. So GBS is a post-infectious immune-mediated disease which targets the peripheral nervous system. About 2/3 of patients generally report an antecedent bacterial or viral illness. Does anyone know what the commonest infectious agent is in GBS? Yes, good. And Campylobacter jejuni, very good. And basically with what this image is indicating is that you generally with GBS, although there are several variants, with the classic sensory motor acute inflammatory demyelinating polyradicular neuropathy. So just take note of the addition of the radicular part of the polyradicular neuropathy, because that's a new addition. Starts with sensory symptoms, which can precede the weakness, which then moves to symmetrical weakness in the lower limbs, which then ascends to the upper limbs. And this is where you really need to be worried, because then this is going to include respiratory weakness, which will require ITU. As well as autonomic dysfunction, is also really important to look out for, so they can develop tachy or bradyarrhythmias, labile blood pressure, pupillary changes. So generally the pupil might dilate a bit, or even in some rarer cases constrict, but mostly dilation, as well as gastrointestinal and urinary dysfunction. And then don't forget that they'll have reduced or absent reflexes. And then just in terms of the other subtypes of GBS, so you can have a pure motor GBS, which is actually called AMAN, or acute motor axonal neuropathy, which is quite rare. And then you can have a mixed motor and sensory, which is also called AMSAN, which is acute motor sensory axonal neuropathy, which would have paresis in the lower limbs, but would include motor and sensory symptoms and signs. And then rarer ones would be the pharyngeal, cervical, brachial GBS variant, and even more rare, bilateral facial palsy with paresthesia. But the main differential diagnosis in our patient was, of course, Miller-Fisher syndrome, like Dr. Bihari accurately said very early on. And I think this diagram is quite good because it shows you two of, I think in this patient, the most life-threatening causes you'd want to distinguish between. So the Bickerstaff brainstem encephalitis and the Miller-Fisher syndrome. And the main differentiator, like I said before, is the fact that our patient did not at any point have impaired consciousness. Also in Bickerstaff's encephalitis, you can also get pyramidal tract signs. So you could get increased reflexes at the beginning, which would also be a good differentiator. So just in terms of Miller-Fisher syndrome, it is a variant of GBS, like I've said, with rapid onset ataxia, areflexia, and ophthalmoplegia. Sometimes it can descend, but generally these three symptoms happen quite close together. It usually follows a viral illness in the preceding 5 to 10 days. And like we mentioned earlier, the most common causative agent is Campylobacter jejuni. Other agents are CMV, EBV. There have been quite a few cases of COVID-19. So just having COVID-19 illness itself, as well as post-vaccine, there have been some cases of GBS and a few cases of Miller-Fisher syndrome, varicella zoster virus, and Zika virus. Does anyone know why Campylobacter specifically is such a common cause of GBS? You can't answer.
No.
Is there a clue on this slide?
A big one. The whole slide's a clue.
Anybody? Here we go. Cross activity of antigens.
Good. That's one part of it, but it's because in our nerves, in the human nerves, the specific antigens in Campylobacter itself are very similar to our antigens. So once you have an infection and there's some antibodies which form, there's molecular mimicry, and of course the body mistakes those antigens for its own antigens and attacks them basically. And these antigens, yeah, that's basically it.
So when you say molecular mimicry, you mean
Yes.
the bacterium deliberately expresses some human antigens to try and evade the immune system, and then we get caught.
No, it naturally just expresses the same specific antigens that are actually coincidentally found in human nerves, and the nerves specifically which this antigen are found is 3, 4, and 6, as well as some of the muscle spindle fibers, as far as I know.
But I guess what Mona is saying is that it's evolved to develop those to try and avoid antibodies binding to it, right?
I think
I
it's
guess
to do with also the
probably.
it's something to do with so there's a glycoprotein within the cell wall of the bacteria that's involved in it entering cells, I believe. So I suspect that the antigenic similarity must be to do with transporters and uptake. But yeah, certainly it's very, very, very close to the ganglioside structure.
Yeah, so another thing is that the specific antibody that you find in Miller-Fisher syndrome, which is GQ1B, gangliosides, are abundantly expressed in the myelin sheaths, just in humans, as well as in the myelin sheaths of the extraocular motor nerves, neuromuscular junction, and dorsal root ganglia. So this is what's postulated as the explanation for the relationship between the development of the anti-GQ1B antibodies and the ophthalmoplegia. And then again, testing for these IgG anti-GQ1B antibodies are highly sensitive and specific for Miller-Fisher syndrome. But again, in our patient, this result I've just checked is still pending. So it's not something you'll use acutely, but it's something that you could look at retrospectively in an outpatient neurology clinic, for example. Again, another important sign is the electrophysiological findings, which would commonly include reduced sensory nerve action potentials and absent H reflexes. I don't expect anyone to know about this. This would be something that would be done with EMG.
Yeah, the nerve conduction.
Yeah, the nerve conduction studies, yeah.
Have you done them?
No.
Yeah, he did have them, and over in St Mary's, and it was unremarkable. So I think the important things with Miller-Fisher syndrome is in GBS, there's various abnormalities we expect, both from the nerve conduction and the lumbar puncture. It takes sort of 10 days or so to develop. So if you do them very early, you'll often have to repeat them. Right. But the high protein you see on the lumbar puncture, for example, in GBS, is because of inflammation of the nerve roots. And because this is much more restricted to the bulbar region, you don't get that inflammation there. That happens much less likely in the Miller-Fisher variant. It probably is about 80–90% in classic GBS if you do it properly at the right time, but probably around 30–40% in Miller-Fisher, so much lower. The same for the electrophysiology, because the abnormal nerves are much more restricted to the bulbar region, which you don't really test neurophysiologically. You're much less likely to find the typical findings compared to GBS.
Thank you.
If we just look at this diagram quickly, it just shows the antibody which is prevalent in the muscle spindles, and then basically this is why you get the ataxia, because you get the deposition in the muscle spindle fibers. And then again, the same thing happens in the oculomotor nerves. And then again, for BBE, this can happen in the reticular formation, and that's why you get CNS involvement with bigger stuff, brainstem encephalitis, but not with Miller-Fisher syndrome. Okay, so I think I will go through this in 2 separate slides, but I just wanted to go through an approach to diplopia, because this could have been really useful in just pinpointing the main differential diagnoses for this patient. So we'll start with looking at diplopia on its own. So firstly, if the diplopia, the main distinguishing factor is whether it's monocular or binocular. And if it's monocular, meaning it's only in one eye, does it correct after doing a pinhole test? And if it does, then it's likely a refractive process that's ongoing. So some corneal abnormality, a dry eye or cataract. And generally you could see proptosis or chemosis of the eye in a patient with this kind of refractive process going on. And if pinhole does not correct the vision, then you need to be thinking of a cortical process like cerebral polyopia or a psychogenic cause. So cerebral polyopia, I had no clue about it before, but it's extremely rare, and it refers to seeing two or more images which can either be arranged in rows or columns or diagonally after fixating on a stimulus, and it can be an indication of occipital lobe epilepsy. And then the second half of the pathway, so if the diplopia is binocular, so both eyes, is there apparent orbital disease? So is there some kind of cavernous sinus process going on, or thyroid myopathy, orbital myositis, or orbital apex process, or trauma? So something for cavernous sinus syndrome, there might be involvement of other cranial nerves, so 3, 4, 6, as well as V1, so the ophthalmic division, as well as maxillary division of the trigeminal nerve, as well as sometimes autonomic fibers can be involved, which can give you a Horner syndrome. And then moving on, if you think that there's no apparent orbital disease, so you don't see any features of thyroid myopathy, you don't have any other cranial nerve involvement, there's nothing obvious looking at the eye, you then go on to, is pain a prominent feature? If it is, you need to be thinking of an aneurysmal SAH, vertebral artery dissection, cavernous sinus process again, and giant cell arteritis, and then finally infectious causes like bacillar meningitis. And if pain is not a prominent feature, then you can think of cranial nerve mononeuropathy. And especially if they're elderly or have hypertension or diabetes, you could think of microvascular ischemia. But if they're not, you need to always exclude brainstem mass or aneurysm. And if you're not suspecting a mononeuropathy, so more than one cranial nerve is involved, then you move on to, is this then a cranial nerve polyneuropathy? And again, could it be cavernous sinus process or orbital apex process? And then finally, if there are other neurological deficits present, like in our patient, you need to look at whether it's localizing to the brainstem itself. So, for example, a brainstem stroke, which would be quite acute. You could have various symptoms depending on whether it's in the midbrain, pons, or medulla. But common symptoms would be vertigo, dizziness, severe imbalance, loss of consciousness, and plus minus slurred speech. Bacillar meningitis, multiple sclerosis, like someone mentioned earlier, and finally brainstem mass. But if there's nothing localizing to the brainstem, like in our patient, we think of another abnormality. So botulism, except there was no abdominal pain or history of diarrhea or ingestion of any recent food. So for those who are not familiar with botulism, the causative organism is a bacterium called Clostridium botulinum. Yeah, exactly. And it's actually an anaerobic organism found in soil, and it affects tinned foods. And when you do have symptoms, so what happens is the Clostridium botulinum creates a neurotoxin, which then attacks the central nervous system. So this is why you get very acute onset of symptoms. Another differential, a good one, would be Wernicke's encephalopathy. I think someone mentioned vitamin deficiencies earlier on, because with Wernicke's encephalopathy, you'd also get ataxia, ophthalmoplegia, but you'd also get a bit of confusion. Again, though, our patient, although he was vegetarian, he denied drinking any alcohol, or there were no other clinical features of B deficiencies. And then our top differentials, Miller-Fisher syndrome and myasthenia gravis, which we said was unlikely because there were sensory signs and there was also no fatigability.
Just one thing to say also on botulism. So it's very, very important to identify that as early as possible, because you can give the antitoxin, which can be life-saving. And typically we do associate it with canning problems, but that's really more of a sort of Victorian problem or a sort of non-UK problem because food standards are generally higher unless it's home canning. Much more commonly these days is wound botulism, which you need to think about in your IVD drug users, so particularly if they're doing skin popping and other things, so you can get botulism that way as well.
Okay, so we're moving on to investigations that our patient actually had. So firstly, we'd want to do a peripheral neuropathy screen to make sure that there are no other causes. Can anyone think of any investigations which would be included in a peripheral neuropathy screen? I think there's a care set on Sana.
Yeah, or any neurology entry which has that big long list, basically.
Yeah, but this is maybe why people don't know because you always supply us with the answer. But anyway, you'd want to check the patient's glucose levels to make sure it's not diabetes related, metabolic profile, so calcium, magnesium, phosphate, usinase, B12, folate, thyroid function, sometimes heavy metal screen, drugs and toxin screen, and autoimmune screen, so ANA. And then in terms of this patient, like I said before, we did the gangliosides, which are actually a whole panel of ganglioside tests, but the most specific one for Miller-Fisher syndrome, as well as Bickerstaff brainstem encephalitis would be the anti-GQ1B antibody, which is highly specific and sensitive. You'd also do myasthenia immunoglobulins, which was done, and then a serum protein electrophoresis. So why we do the serum protein electrophoresis is there is quite a rare cause of neuropathy, which has monoclonal gammopathy, which responds well to chemotherapy. And this is the only reason, if anyone was ever wondering why would we randomly do a serum SPEP, yeah. And then just in terms of infections, always think infections. So HIV, hepatitis serology, atypical pneumonia, because mycoplasma can also cause GBS very rarely. Creatinine kinase, syphilis serology, because syphilis is just a mimic of a lot of things, but generally nowadays we don't see that much syphilis anymore. And then finally, Campylobacter serology. In terms of imaging, we need to do a CT brain before the lumbar puncture just to rule out any space occupying lesion or contraindication to a lumbar puncture, which could cause, or features of raised intracranial pressure, which then could cause coning if there is a mass lesion or something. In terms of lumbar puncture, generally the CSF protein will be raised in the patient with Miller-Fisher syndrome or GBS, but the white cell count should be normal. And in terms of a contrasted MRI, brain and spine, you can sometimes see enhancement of the involved cranial nerves. So for example, cranial nerve 3, 4, and or 6. And then nerve conduction studies and EMG. Other investigations that are really important at the bedside, which would be to do serial forced vital capacity measurements, telemetry, especially in the acute phase. So you'd want to have them on cardiac monitoring to monitor for any of those, any of the autonomic features, an ECG, lying and standing blood pressure, and chest X-ray, just to rule out that there's anything else going on in the lung, because he did have a preceding respiratory tract illness. So this is just an example of an MRI brain and what would actually show with someone with Miller-Fisher syndrome.
This is,
oh, this is
yeah,
it.
yeah.
Oh, sorry, this is his. Sorry, Matt kindly sent this to me this morning. So this is actually in our patient. So he had a very mildly enhanced thickening of the oculomotor nerve, more on the right than the left. It's very subtle. It's this,
Yeah.
isn't it?
They're really small and you really normally struggle to see them, whereas you can easily see them on both sides
Yeah.
here. And actually you can see on, given the anatomy here of why this is affected with uncal herniation, when the temporal lobe, if that shifts just a little bit across medially, it's going to compress the nerve.
So what you're saying is if you see them, there's like
If you can easily see them, is that your problem? Yeah.
Yeah,
Okay.
that's pretty good.
And this is the post contrast. You can see that the right one in particular, when you compare it to the left, is brighter with the gadolinium.
Just in terms of management, another thing that's really important is why we would do immunoglobulins, which I didn't really mention on the last slide. But if you're thinking, if you have a patient with Miller-Fisher syndrome or GBS, and you're thinking along the lines of treating them if they have rapid progression, so in terms of immunotherapy, it's really important to do the immunoglobulins before considering any IV immunoglobulin. And this is because if the patient has an IgA deficiency, they are more likely to develop a severe anaphylaxis to immunoglobulin. So if they're deficient, our patient was not, then you would not give them immunoglobulin. And then importantly, just to emphasize, measuring the baseline FVC with serial monitoring at the bedside. Also just checking up on the patient if they have any breathing difficulty and to call ITU as soon as they do. Other indications for ITU review would be any autonomic dysfunction or rapid progression of weakness. Also just keep them nil by mouth until there's a formal swallow assessment. You can't just do one at the bedside and then get SALT to review. And cardiac monitoring is really important because they can just deteriorate at any point. And neuro observations. And then in terms of immunotherapy, for GBS, in terms of treatment for GBS, trials have shown that IV immunoglobulin versus plasma exchange, they actually don't affect the disease mortality rates, but more help you get to a place of basically plateau of symptoms faster. And this is the same for Miller-Fisher syndrome. There are no specific studies with IVIG in Miller or plasma exchange in Miller-Fisher syndrome, but the thinking is basically the same as for GBS, that if the patient is progressing faster, either IVIG or plasma exchange will help them get to that stable plateau phase where they won't develop any more weakness. But for example, if they were meant to have severe weakness and they get IVIG, they will still develop that weakness regardless of either immunotherapy. In terms of choosing which one, so plasma exchange is much more complicated, much more expensive, and has a lot more side effects than IVIG. The only problem really with IVIG is the risk of anaphylaxis. And then finally, importantly, supportive care, analgesia, because patients with GBS and Miller-Fisher syndrome do develop chronic pain syndromes. Always remember DVT prophylaxis and rehabilitation. Just a side note is also just not to forget if they have any ptosis or eye involvement, to just take good care of the eye because you don't want to develop corneal ulcers, as well as to also think of the patient's psychological status, because they can become quite depressed with weakness, sudden onset weakness and chronic pain. Sorry, we're almost at the end. So basically in our patient, he received IVIG over 5 days and he was stable on discharge. I believe he's recovering well, and he had a good outcome. This is just showing an example of in GBS, the course. So generally you have your infection here over 1 to 2 weeks, and you have the peak of your serum antibodies to the gangliosides. And then you can see how long recovery can actually take. And this is why follow-up and rehabilitation is so important. Yep, this is the end.
That was really good, really clear, and really interesting.
We just have the quiz. Do we have any time?
I don't think we do. I think it was better just ask. Well, I don't know. What do you think? Yeah, we've only got 5 minutes left.
It'd be tricky to, if they've all got to join on, but we can do it on the polls if you want to have a go at like this.
I just don't know how to work the polls.
No, I'll do it. I've got they're in front of you now. Can you see the poll?
Or if you can do the Kahoot.
You can do Kahoot. It's easy. Prof. Miller really wants to do his poll. Let's do the poll.
Right. I don't mind. It's just that let's join Kahoot and put. We can try Kahoot. Go on then. Let's do it. I just wonder whether we'll all be able to join on a. Go on. We need a code and stuff, don't we?
Yes, the code is on the screen. I think it's being shared.
No.
Oh.
We can just see that Matthew Evans is the best neuroregistrar ever.
I hope your consultant's watching.
This is the one. They were saying.
Oh, look at the other
Let's
neuro.
stop sharing. Let's screen share, and it's here.
Okay, can you see the code now? It's
Yeah, we can.
32503770. Someone that's in it to get 100%.
Keen to win the second one, no. We're flying under the radar this time.
So then I just click start then.
Let's give it 5 more seconds then.
Fine.
So I'll put my name in and it still says waiting for players, doesn't it?
Yes, so we're just going to give it a few more seconds and I'll start.
Oh, I see.
Everyone ready? Okay, let's start. Wow. Very dramatic.
You set load time, it's good. So we'll be fast.
Oh, I see.
Good. MA, not wanting to tell us who they are. Good.
Oh, that's a hard question.
But I mentioned it.
That's rapid interpretation from the numerals.
Oh yeah, sorry. Apologies.
Ah, good discriminating question.
Oh, the AMU Med MA again, an AMU Med student.
Can you explain that?
So
Just because your body's never sort of been exposed to IgA, and then you give
before,
called
and then you give yeah.
I mean, actually, there's not really very strong evidence for it, and most people now would argue you just go ahead and give it anyway, and just be careful.
That's
Okay.
really helpful. Thank you.
Oh, Emily's on fire.
See.
It does not improve outcome, but like I said, it helps you to get to a stable plateau phase if the patient was meant to get there faster.
Exactly. It speeds up time to the end stage, but the end stage will be the same.
Yeah. I think we're gonna have a double winner. My Sarah.
1 point in it. It's tight.
I got difficult here.
Oh, controversial. No, as in type the answer. Free text.
I didn't actually mention this. This is a bit of a mean question. Yes, so we never, ever use steroids in Miller-Fisher or GBS because trials have actually shown them to worsen mortality rates.
These type of answer ones are tricky because you got to work out what people are going to say.
And it only gives me a limited number of letters.
Somebody got it.
Good, someone said respiratory weakness, good. Oh, props climbing. So yes, studies have shown that they both are equally as effective in getting you to that stable plateau phase, and
Yeah.
you'll either be getting there with or without IVIG, but it's just to help speed up the process. Yeah, do you have anything to add?
No.
Good, very good. And last question. The winner can come find me in AMU doctor's office.
Is this question specifically Charing Cross or around the world?
Around the world.
I was gonna say actually,
None of the above.
I would just say one controversial thing about that.
Yeah.
I think probably that's true for what most people would do in clinical practice. The AVN guidelines for lumbar puncture say in young people with no pre-existing neurology and no liver problems, etc. Actually, if you need to note an LP, you don't have to do blood, you don't have to do imaging. But I think most people in practice are still medically legally concerned, so they do. Guidelines say you can risk assess it.
Well done, everyone. So A can come find me in AMU doctor's office. Thanks, everyone.
Who is A doc?
Yeah, who is A doc? That's the question.
If it's Stephen Auger, he doesn't get a prize because he's
Fine, if it's Stephen Auger, yeah, no prize. Agreed. So then it's Emily, isn't it?
No, it's not. It's really, really good talk and really complex things explained really simply. So my understanding has increased dramatically. Thank you. And there's really good slides in the Diplopia and how to determine what the causes. Thank you.
Okay, thank you, everyone. So can I have any thoughts about moving to face-to-face with Zoom as an option for next Friday? Next Wednesday, that's going to happen. Okay, for the grand round at 12:30, you can go to the 10th floor in the lab block, which is open. There's no lock or anything. You can just walk in there. You don't need a card even.
Let's do it, Cream. It sounds like a great idea. It's nice to do some face-to-face teaching.
Yep, lovely.